Good morning, and welcome to those of you who are joining us here in the room, and also good morning to those who are joining us from the virtual audience. As a reminder to those who are attending the virtual audience, there are interactive features that you can use via webcast, and we hope that you will take the opportunity to ask questions. Again, my name is Elaine Stedt, and I am the Director for the Office on Child Abuse and Neglect, and it is my great pleasure to welcome our two distinguished speakers to the stage. First, I will just give a brief introduction to them, but then I also ask them to just say a little bit more about themselves and really what they've been doing in the field you'll hear more about. But first, we have Dr. Nancy Young, who is the director for the National Center on Substance Abuse and Child Welfare, and has been working in this area for many, I will just say I've been working with her for the past 16 years at the intersection of substance use disorders and child welfare, and really is a pillar in this work. Next, I would like to introduce Dr. Melinda Campopiano, and she is the medical officer for the Center for Substance Abuse Treatment at the Substance Abuse Mental Health Services Administration, and also another pillar in the field and has been working to create innovation and really looking at how do we best get out the best practices out for women and children who are affected by the opioid epidemic and also this crisis. And so really, it's my pleasure to have them here. I really hope that you guys ask a lot of questions, and I'm looking forward to the discussion. Thank you.
Great. Thank you very much, Elaine, and thank you so much for the opportunity to share information with you today. Let me start by saying that we are sponsored by both the Administration for Children, Youth, and Families and the Substance Abuse and Mental Health Services Administration. And you see on the screen our website, NCSACW, it's a little bit of a mouthful, .samhsa.gov, but National Center Substance Abuse, Child Welfare. And if you haven't had the opportunity to visit our website, all of the resources that we'll be talking about today are located on the website. There is a whole several pages that are devoted to resources specific to opioid use disorders and treatment, as well as many webinars that have been conducted. So I would definitely encourage you to visit the website. So we're going to talk a little bit about the data on this current issue, explore some of the issues related to prenatal substance exposure, what we've found works when we're talking about parents with substance use disorders and child welfare, a little bit about where are we going to go next with how we address these issues, and then Dr. Campopiano will be able to spend a little bit of time talking about what is treatment for opioid use disorders, and particularly the implications for pregnant women and prenatal exposure and what treatment looks like and should look like. So let's get started. First, let me say that these are data from SAMHSA, 8.3 million children in the country that live with a parent who is alcoholic or needs treatment for illicit drug abuse. It's kind of hard to wrap your head around 8.3 million children, but it translates to 11%, which means in every school classroom, there are about 3 children who go home to a parent who is alcoholic or needs treatment for illicit drug abuse. So I use this slide and these data often because it paints the picture, I think, in the beginning of the challenge for child welfare to understand the implications of parental substance use disorders and how they might contribute to risk or safety factors, which is really the key task of child welfare, is to determine those conditions that may be putting a child at risk and may have immediate safety factors. So when we think about substance use disorders in parents, I hope you go away with this picture of 3 kids in a classroom and that challenge to determine when does that cross the line of abuse or more likely neglect. That means that child welfare needs to intervene. But we've been here before. Child welfare has been working with parents with substance use disorders for decades. The 60s with heroin at that point, the 80s and cocaine, the 90s and methamphetamine, and now we have the 2010s and prescription drug, particularly prescription opioid misuse, and the heroin use crisis. So I the point of that is really to draw on the strengths of what's worked before, of how these crises and changes in drug use patterns have affected child welfare practice in the past, and to remember that we've been in this situation before. Clearly, the opioid use crisis in our country is distinct by the number of overdose deaths that we have never seen in our country before. And that too has implications for child welfare as more kin providers step in to care for children whose parents have died. But it's also an era that we can take a step back and really look at what we have learned, particularly in the last 10 to 15 years, about the neuroscience of addiction and how we engage parents in treatment. It's important to recognize, as Dr. Volkrow, who is the director of the National Institute on Drug Abuse, says, that substance use disorders are a developmental disorder of adolescence. And this comes into play in child welfare as we see young people, junior high, high schoolers, who are both experimenting and moving on to more continued use. But the prevention efforts that are needed during that critical time period of most individuals who develop a substance use disorder started that use during their adolescence. So a developmental disorder of adolescence, I think, paints a frame of the parents that we're trying to work with, the parents that we're helping, to remember when their substance use started and some of those implications as we're writing case plans and working with parents to think about those developmental milestones in adolescence that were needed before these individuals became parents. The other part of the brain science that has advanced so tremendously in the last decade is that we know now the mechanisms of addiction in the brain and the reward pathway, and that there are brain and behavior implications that come from those changes in the reward pathway and executive functioning of the substance use in the brain. And that those play out in ways that affect judgment, decision-making, learning and memory, behavior control. I think as you think about the last case that you may have been working with in which the parent had a severe substance use disorder, and you get the case plan signed and you walk out the door and it's great, this parent is really on their way. And then remembering that their brain has been affected in a way in which the neurochemistry has been affected, and that neurochemistry affects their judgment, decision-making, learning and memory, and their behavioral control. When you have that perspective as you're working with parents, I think it changes practice to say, what is it that we would walk out the door and leave behind? What kind of follow-up may be necessary? That motivational interviewing and motivational factors may be critical, particularly in early stages of abstinence. So those implications for child welfare practice are profound, especially as we recognize the number of parents that are dealing with a severe substance use disorder in our practice. But we also know that substance use disorders are treatable diseases, and that we have much more science today about how to both intervene during the critical period of early abstinence, as well as the ongoing supports that are needed. In fact, as we look at addiction and substance use disorders as chronic diseases, and to think about how we manage other chronic diseases in our healthcare system, not episodic, go to this program and everything will be fine and you come back and everything is taken care of, but rather a chronic disease management approach. Now, those of you in the audience might be saying, well, how does that fit with child welfare? And we'll talk a little bit about that. But a more recent article written by three of the real pillars in the field of addiction research are talking about this new paradigm of disease management and making sure that we have a 5-year plan that we're talking about to look at recovery, that substance use disorders are treatable, that people recover, but we need to be thinking about this as managing a chronic illness rather than episodic kind of ER, emergency room kind of an approach, where you go into treatment and come back and then repeat that, but rather the disease management approach of understanding prevention, understanding relapses, understanding a lapse, meaning returning to use without fully going back into some of those other issues that occur with consequences of substance use disorders. So again, a different perspective to think about substance use disorder treatment and what we're trying to instill in treatment agencies in particular about this view of a chronic disease management, just like individuals are managed with hypertension or diabetes, to have that kind of a perspective. That 5-year plan, or that 5-year approach of saying disease management is based on the models of treatment from other, again, cancers with behavioral consequences, behavioral components in that disease process. And ensuring that that long-term recovery is the measure for effectiveness, not the 30 days they've stopped using in 30 days, but that we're looking over a longer period of time. Now, again, I recognize that that may sound very challenging for particularly families in which a child has been removed, and the Adoption and Safe Families Act says we don't have anything like 5 years. And it's not expected to be in child welfare practice that you would wait 5 years to say, oh, this is a success. Our challenge is to understand what are those markers along the way to recovery? What are those markers of stability with a family that they can either be reunited or that in-home services have been successful and that child welfare can step down in their interactions with the family, and perhaps other recovery supports in the community are brought into play to help support that family over the longer term. There are two aspects we're going to talk about today in terms of how parental substance use disorders may affect that child's well-being. The first being prenatal exposure, certainly what has been in the media and in the news. Again, we've had these kinds of epidemics in the past that get a lot of attention. It hasn't necessarily eased in the caseload, but just had more of a focal point because of the media attention more recently. And then that postnatal exposure in families for children. These are data from a couple different sources that primarily from, again, SAMHSA, that looks at the Survey on Drug Use and Health to estimate the number of infants who are affected by parental substance exposure. You see that the bar on the left and the second bar to that are the legal substances, and understanding that the legal substances also have implications for fetal development, particularly tobacco and heavy use of alcohol. So when you see those bars and say, well, why are we even talking about those legal substances? Because they are much more prevalent. They contribute to the neurodevelopmental effects, particularly related to alcohol exposure, that we may be seeing in young children that may have not been diagnosed or understood during the prenatal period or at birth, but recognizing that they contribute when there is also illicit substance use. And generally they go together, smoking, alcohol, and illicit substance use. And the science around the legal substances of tobacco and alcohol is so much more advanced to understand the implications of alcohol. It's why we have warning labels on all alcohol bottles and in stores that sell alcohol about use during pregnancy, and that those neurodevelopmental effects are much better understood than some of the illegal illegal drugs. And in fact, when science tries to separate out which was the contributing factor, it's very difficult to do because it's very rare that you would have a mother, a pregnant woman who is using illegal substances who's also not using alcohol. And we understand the implications of prenatal alcohol exposure with neurodevelopmental effects. But the reason to spend some time on these bar graphs is to get the perspective of what pregnant women are using and the much, much smaller number of those infants who are identified with neonatal abstinence syndrome. Again, for the perspective of making sure what is it that we're looking at, and are we letting a particular component drive our policies and drive our practice rather than the whole view of what is going on in terms of help that may be needed for pregnant women in particular and women who have infants who are in our caseloads. These are data actually from hospitals about the diagnosis of neonatal abstinence syndrome. And you see the two regions of the country that at the time of these data collection were most prominent in terms of making diagnoses of neonatal abstinence syndrome attributed to opioids during pregnancy. And part of that awareness of increased neonatal abstinence syndrome has caught the attention of many policymakers. And I'm going to step back just for a minute to remind us about what the Child Abuse Prevention and Treatment Act related to the notification of child welfare said in 2010 with the last amendments. But that the purpose was to identify infants at risk of more often neglect than abuse, to make sure that there was a way that the identification of these infants would be made to Child Protective Services, and that there be a plan put in place to make sure that those children were going home to safe environments, and that the children had the interventions that were needed. And that the law states specifically that the identification of infants with prenatal exposure at birth and the notification to Child Protective Services should not be construed as de facto child abuse or neglect but in any of the federal law, or that it should constitute grounds for action in the criminal courts. More recently, as the CAPTA has been looked at specifically related to opioid use disorders, is that notification to Child Protective Services and the plan of safe care is to be developed for children who are affected by illegal substance abuse, withdrawal symptoms, or fetal alcohol spectrum disorder. I believe it's a little difficult for me to see it on the slide, but the big change that has happened now that was signed into law from the Comprehensive Addiction and Recovery Act made changes to CAPTA, the Child Abuse Prevention and Treatment Act, in some very important ways. That the same kinds of information about the intent to be able to identify and to notify child welfare, but that makes some key changes. One is that it no longer says illegal substance abuse. Two is that the plan of safe care should be addressing both the needs of the infant and the family or caregiver. This is a wonderful opportunity for us. It's a wonderful opportunity to make sure that we're partnering with our treatment agencies to understand what the needs of the mother and the family, the father, other caregivers might be in order to ensure the safety of the child. That development and implementation of the plan of safe care means that there need to be monitoring systems in place regarding the implementation of the plan. It doesn't say that Child Protective Services is the only agency to implement that plan of safe care. And we're very hopeful that there will be partnerships created. For example, if the mother is receiving medication-assisted treatment and is stable receiving those medications and participating with her treatment provider, there may not be a need for Child Protective Services to intervene in the life of that mother. But you would probably want to have the partnership with that treatment provider in order to ensure that if something were to change and mom needed some help, that there was a plan in place about what that meant for mom to be able to get that help. If the conditions in the family changed or something else was going on, what is the plan about what mom or the other caregivers are to do to ensure the continued safety of the child? And that plan is about both what services do they need, as well as the delivery of the appropriate services. The notification means that there are data that are generated, and in fact, that the state agencies and the Children's Bureau will be asked to report through the ongoing data monitoring systems about the number of infants who were identified, those that had a plan of safe care developed, and the number of infants for which a referral was made to services, including services for the affected family or caregiver. It really grounds practice in family-centered services. So we're very excited to see this change as an avenue of being able to say this is about the family's well-being, it's about two-generation programs, it's about identifying that the baby and the caregiver and the family may need referrals to services, may have needs that should be addressed by, again, this partnership in the community between the hospitals, public health, home visiting, substance abuse treatment, Child Protective Services, ongoing services. It really creates that opportunity to bring those services together. So what's happening in terms of the number of children who are coming into care? These are data that you are probably familiar with by now because it's day 2 of the conference, and we all recognize that after a decade of decreasing numbers of children entering out-of-home care, that the last couple years have seen this uptick. There's been a lot of discussion about is that attributed to the opioid epidemic? It's very difficult to say that at this point in terms of any data that really are coordinated in a way that you can certainly not say that there's a causative factor, but there are certain data that appear to be associated, particularly in certain regions of the area of the country. But not all regions are experiencing high rates of opioid use disorders or opioid deaths, and yet children are still coming into care at higher rates. So we think there's something else going on. These are data that come from the AFCARS report, in which workers are asked to indicate in the information system, is parents' alcohol or drug use a factor in the case? Now, I can tell you that we've been to every state in the country, and not a single state believes that these are reliable data, that they don't believe that they're accurate, that they are severe undercounts, because when we ask caseworkers and supervisors, they say it's certainly more than half of their case. When we ask judges, they say it's somewhere in the family with caregivers that substance use disorders are present. So we think these are severe undercounts, and here's the reason why. Those names across the bottom of the slide, which are very hard to see in this large room, but if you're interested in these data, we have a handout at the exhibit booth that shows those in detail. But you see the variation by state in terms of the reporting really of checking that box to say that parental alcohol or substance use was a factor in the child's removal. Those range from less than 10% to almost 70%. We don't believe that this is a very big, the variance is by state in terms of real prevalence. We think that these are reporting issues and identification issues. We know that the states that have those higher points that show higher prevalence are actually states who have created uniform screening protocols and data collection protocols to better understand families that are coming into their system with substance use disorders. We'd be happy to share that information with you. Please email us or get in touch with us, again, at the exhibit booth if you're interested in knowing what those protocols look like and what it took for these states to get a bit more accurate data in terms of parental alcohol or drug use as factors in children removal. So it's difficult then when you look at those data to say what is the implication of substance use and the prevalence of substance use in the child welfare caseload. But this is back to then the overall rates, and this is what is particularly disturbing when we look at the more recent data, 2014 in this case, of the number of children who were placed in protective custody by age. By far the largest group are infants. That would lead one to make some connections that are these infants that were identified at birth, or perhaps they came in at a few months of age into the system. But it's hard to imagine that there were infants coming into the system for very many reasons other than the parent's substance use during this time. And certainly it could be that there wasn't prenatal exposure, but I think that our systems, and particularly our referrals to the Part C agencies, need to make sure that we're understanding that it's very likely that these infants were exposed to substances in the prenatal period and that they need specific developmental assessments and interventions, just as the CAPTA law says all children under 3 will be referred for those developmental assessments, and that awareness that prenatal substance exposure may be playing a role in their neurodevelopment particularly if they were exposed to high rates of alcohol use during pregnancy, which may not have generated full fetal alcohol syndrome, but perhaps affecting the child's neurodevelopment and why we might be seeing some of those lags in development in the early ages. So what are some of those policy and practice issues then related to those data, which are, we often say the only reliable thing about the prevalence data in AFCARS is how completely unreliable it is. What are those policy and practice issues? Again, it's the identification. Does your county, does your agency, does your state have a uniform way in which they're asking about substance use and its relationship to the abuse or neglect which is causing a child to be removed? Those variations, again, are about the identification as well as the system to record it. In most states, there's no clear protocol for workers about where in the information system is that box to be checked so that we can look at data in the future that really documents what is the prevalence in order really to drive resources to understand what that need is in the child welfare caseloads. So we use this term, do we care enough to count? And I recognize that agencies all over the country are in this business and workers are in this business because they have profound care for children. And this is the challenge. Do we have that ability then to take this next step to understand better the data about the number of infants with prenatal exposure? And I won't run through all of those 5 data points, but would encourage you to come back to this slide and understand what the data are in your own community, in your own agency right now. So what works? That's a lot of the data and the problems. So what works? And the good news is that the federal government over the last 15 years has invested in various demonstration grants that have documented what communities actually do in order to address this crossover population or with parents with substance use disorders in child welfare. I'm going to highlight outcomes from 2 programs. The first round of the regional partnership grants and a round of family drug courts that were funded by SAMHSA that were specifically asked to improve their children's interventions and the parenting interventions. In the first round of regional partnership grants, there were 53 programs, 25,000 children. In the children affected by methamphetamine family drug courts, there were about 5,000 children and 3,200 parents across the 12 family drug courts that were funded. What we ask these sites to do is tell us what you're actually putting in place. What are the practice issues? What are the things that you're doing? And we have pulled from those qualitative data across all of these grant programs. What are the things in common that these sites do? Number one sounds familiar because I've just been talking about a system of identifying families that have a parent with a substance use disorder. Earlier access to assessment and treatment services, the various models about how they've outstationed staff or had a way in which they were improving that time period between the identification of a substance use disorder and getting access to treatment. Improving the family-centered care, again, that idea of the 2-generation programs, that parenting classes needed to have opportunities to practice those skills with children, and that there needed to be an opportunity to repair any of those parent-child relationships that may have been at risk during this time of the parent's substance use. Improve management of the recovery services. In other words, it's not okay to just give a list of phone numbers to a person in early abstinence or active addiction and say follow through, because remember that list of those things about what gets affected in the brain and during a substance use disorder. So it's not okay to just say here go to treatment, but that there has to be some way that we're improving the recovery services and monitoring compliance in a proactive, engaging way for parents. That there's some response that says that we're not waiting until the 6-month court hearing, but parents are coming back if it's a child who's been removed, that every 30, 60, 90 days. So we're checking on what's going on in treatment. We're not going to wait until right before the next court review, but we're going to make sure that parents have a way to ensure that they have been able to get access to treatment using the science of contingency management, which is a well-documented, evidence-based program in substance abuse treatment, that there is a way of making sure that there are either those judicial reviews if the child has been removed, or many communities and states around the country now are implementing administrative oversight for in-home cases. And we're very excited by that in terms of making sure that they're getting the follow-up that's needed about their participation in substance abuse treatment prior to a child needing to be removed. And then obviously this collaborative approach, which says that there are certain factors that must be paid attention to in order to have the systems in place that can support those changes in practice. And what we found from those demonstration sites is that those programs taken together affect these 5 R's of outcomes in very dramatic ways. Again, we have a flyer at the exhibit table if you'd like more detail about that and all of the outcome data, but let me just focus on 2. The reoccurrence of child maltreatment. You see that value for the CAM children, these are the family drug courts, was about 2.3%. I'm sorry that it didn't show on the graph itself. And then 3.4% And it's about, I'm not going to remember off the top of my head, but it's 6-point-something% in the states in which these regional partnership grants operated. So very dramatic differences when we look at the recurrence of maltreatment. Similar kind of data when we look at reentry to foster care. Those percentages are again in the 2% rate compared to about 12%. And I'm sorry those data didn't come out. We actually checked it last night on the computer to make sure that it was going to transfer correctly. So here's what we do know. Child welfare can't solve this problem by themselves. They need the partnerships with the other community providers. There needs to be a way in which we're engaging the substance abuse treatment agencies, hospitals, public health, OBGYNs, to make sure that we're intervening when we can and make sure that we're providing this family-centered approach that focuses on both the child well-being and the family well-being, because I think we all recognize that children do best when they're growing up with their biological families and their parents whenever they can. A new resource we're delighted to be able to announce, just out for a couple weeks. Again, that's on our website. A few years in development, consultation with many professionals from around the country about how to work with families in the child welfare implications of the opioid use disorders and pregnant women. Drawing again on those partnerships across systems. It's guidance to states. It has many tools in it as well as current data, and really geared to a broad audience of partners that need to be teaming in order to address these issues. It's built on a framework that the National Center has been using for quite some time, meaning that the point of intervention is not just at the point of birth, but in fact, when we think about those alcohol labels on bottles, that's really pre-pregnancy prevention, and that there is a time period during prenatal care in which there is an opportunity to intervene and ensure that mom is in treatment and getting the interventions that she needs. Waiting till birth is almost not in a preventive way. That's what most public policy does, is wait until birth. And we're really trying to encourage, again, that partnership in that prenatal period. And I can hear child welfare workers that are listening virtually and in the room saying, wait, we can't intervene until the time of birth. And I think that's one of the challenges for us to think through. If we know that our responsibility is to ensure a plan of safe care, there are communities that are figuring out how to make sure that that plan of safe care is developed in partnership with treatment agencies and the doctors that are treating the mother prior to birth, so that we can reduce those number of crises that child welfare is responding to. So clearly then that need for ongoing follow-up, I've mentioned Part C already, and then the ongoing supports that children may need as they are going through those various developmental stages. So again, this idea that we want to be able to back up a bit and say, before birth, what are the community responses so that we're not waiting until the time of the crisis when the child is born? Part of that we've learned from a collaborative group in Burlington, Vermont, and this case study is written into that monograph that I just mentioned that gives the details about how they are doing the sharing of information, what their legal issues were in terms of being able to have child welfare at the table as a collaborating partner, and 30 days prior to birth, opening an assessment track for that particular woman to make sure that there is an understanding. Is this a mom who is receiving medication-assisted treatment and is stable, and child welfare already knows that mom is going to be able to parent this child? She has the supports in place like all newborns need with extended family, and that baby can go home. Or is this a mom who has not been able to be compliant in treatment, and in which case we may need another caregiver? Can we do that identification of the caregiver prior to birth, again, to reduce the crisis at the time of birth, and have a plan in place about, oh, this is going to be grandma's placement, or this is going to be an aunt, or this is someone else that's going to step in, or there isn't a family member, and we're going to have to go traditional foster care. Having that information before is the way in which we can say, this is a plan, this is understood, mom is engaged, grandma's engaged, that we can look at how are we creating those plans so that children are safe and that moms are engaged. Because at this point, we can no longer say we just don't know what to do. We have a lot of evidence, we have a lot of programs that have been able to work on these issues and being able to move forward with addressing these issues. Again, we would encourage you to visit our exhibit booth to get more information on the changes in the CAPTA law and to understand better those programs that have been created to address this issue. And I am very pleased to turn over to my colleague, Dr. Campopiano.
Thank you, and good morning. I want to say just a little bit about my background and who I am to give you some context for what shapes the comments that I'm going to be making today. So I'm a family doctor and I'm boarded in addiction medicine. I've been in government for not quite 4 years. So before that, for 10 years, I was in clinical practice and did primary care medicine and used buprenorphine and methadone to treat people with opioid use disorder, including pregnant women and parenting individuals. So what I'm going to try to cover here today is the basics of medication-assisted treatment for opiate use disorder. What are the goals of it? What is the evidence? What are the recommendations specifically pertaining to pregnant and parenting women? But also what should successful treatment look like for the caregiver in general. And then we'll talk a little bit about neonatal abstinence syndrome. Now, my slides are not so exciting to look at, but I'm hoping that they might be downloadable and printable and useful to you as a reference. And in some cases, if you look at them later in the notes view, you'll find that there are some citations and articles that you can then go look up in the notes section of the slides. So without further ado, it's important for us to start out with a general understanding of what's meant by medication-assisted treatment. The most important thing is that it needs to be offered in combination with behavioral services that are individualized to the needs of the person who's seeking recovery from substance use disorder. Medication is very effective and provides lots of benefits, but it is not going to teach someone how to behave differently or learn the skills that they need to function more effectively in life. Now, this is true of medication-assisted treatment, whether it's being provided for alcohol, tobacco cessation, or opioids. So think about it if you've ever smoked and tried to quit smoking. Hopefully your doctor didn't just prescribe you a patch or something and send you on your way. They helped you develop a plan about how you would stop, how you would deal with triggers, how you would deal with consequences of stopping smoking, such as weight gain, things like that. Think about if you have high blood pressure. If I were going to treat you for high blood pressure, I wouldn't just give you a medication and send you on your way. Or I might, but I shouldn't. I wouldn't be a very good doctor if I did. I should be talking to you about how you're going to manage stress, how you're going to lose weight, how you're going to start exercising. Now, I won't stop treating your high blood pressure if you are not successful at losing weight or starting an exercise routine, but I'm not going to stop trying to support you in changing those habits because it affects the long-term outcome of your condition, and I don't want you to have a stroke. So in the same sense, I want to work with the patient to get the best possible, most fully functional recovery possible for that person. So the medications, now I'm zeroing in on opioid use since that's kind of our topic for today. The medications that are available for the treatment of opiate use disorder, and you may see these in any caregiver that you're interacting with, are methadone and buprenorphine, both of which are opioids. They are controlled substances. They are subject to some regulation for treatment of opiate use disorder. And they do have at least some abuse potential. The third medication is naltrexone, which can be used orally or by injection. It is an opioid blocker, so it has absolutely no properties of an opioid. It's not a pain reliever. It can't do anything like that. And it is not abusable. It is not a controlled substance. It is not subject to regulation. The main, I don't want to call them barriers, the main hurdles, I guess, to overcome in getting it is usually access to insurance coverage for it. It's a somewhat expensive medication in the injectable form. So that's what's on the menu as far as medications that might be chosen to treat a person with opioid use disorder. Now, I'm going to talk less about naltrexone just because it's not studied in pregnancy, so you're less likely to see it in the family of or the mother of a substance-exposed infant. So kind of narrowing down just a little bit further to the opioid agonists. The benefits, the expected benefits of medication-assisted treatment for opioid use disorder is that it reduces all-cause mortality by about half. So that's death from any cause, not just overdose. It reduces HIV risk by about half. It improves adherence to medical treatment, so psychiatric therapies, management of diabetes, hypertension, all of that compliance improves. It improves social function, decreases criminal behavior, and decreases drug use. So the evidence for this is most strong for methadone and buprenorphine. We haven't had naltrexone available long enough, and not all the right studies have been done to determine that it's equivalent in producing these benefits for people. But we infer, to the extent that it would assure abstinence, that people would derive similar benefits from getting that medication as well. But if you look at this slide in the notes section, you'll see that the literature is mainly based on research for methadone and buprenorphine. So now, in the context of pregnancy, what does medication-assisted treatment with methadone or buprenorphine offer to the fetus? The birth outcomes for a pregnancy that occurs in the context of a medication-assisted treatment is similar to that of other obstetric patients. So compared to the untreated substance user, there are fewer preterm births, less intrauterine growth retardation, and fewer low birth weight babies. So these are taking your opiate-dependent mother and making her birth outcomes and the outcome for that individual fetus comparable to if mom were not a substance user. The infant is less exposed to as much illicit substances, as frequently, and as wide a variety of illicit substances. I think I'll talk a little bit about the fact that the medication-assisted treatment does expose the infant to opiates. And how do we reconcile that? So other benefits to the fetus, so less maternal drug use in general of whatever kind, and better compliance of mom with prenatal care. So those are things that being on medication-assisted treatment can bring to the infant. Now, I want to make clear that with the context of medication-assisted treatment, detoxification or tapering off of medications is not really considered treatment. It's considered the medical management of acute withdrawal. In the non-pregnant person, you can connect it to medication-assisted treatment, such as with naltrexone, but by itself, it's not considered treatment. It's an important medical service, but it does not change the natural history of the course of the addiction. Detoxification, if it's medically necessary and appropriate in pregnancy, can be accomplished safely. It's typically done in the mid-trimester, and it requires very close supervision, typically residential services. We don't recommend it because it is very highly associated with relapse to illicit substance use. And relapse after a period of abstinence is associated with a much higher risk of opioid overdose. So it can be done if it needs to be done. It's not the recommended intervention because it doesn't produce the better outcomes for the mother or the child. So that said, I'm going to give you just a little bulleted explanation of methadone versus buprenorphine so that you'll understand the ways in which they're different, but also the ways in which they're similar. And this is about the medications. We're going to talk about the treatment settings that we use to deliver these medications subsequently. So methadone's what's called a full agonist, meaning the more you take, the more effect it has. It's administered orally, so it's swallowed. It may be a liquid or a tablet, but more often than not, it's a liquid. Induction, or getting onto methadone, has to be accomplished slowly because it's a full agonist, and so there is the potential to give a dose that would harm someone. There's also a little tricky piece where the benefit that a person's going to get from their dose of methadone, how much with their withdrawal it's going to relieve, is kind of established before we know how much it's going to depress their respirations. So it has to be done slowly, because you'll have a patient in front of you and you know that they're only going to get this much relief of withdrawal, but you have to wait a little while longer to make sure that they're safe at that dose and before you can try to titrate up. So it takes longer. Because of that, we actually recommend that pregnant women be stabilized in a hospital setting. They can be admitted for high-risk pregnancy and managed oftentimes in labor and delivery, but sometimes just in a regular bed, and kind of gotten stabilized in a safe environment where they don't have access, for the most part, to drugs, and can get stabilized more quickly than they can in an outpatient setting where you don't have the control. The effective dose for methadone is the one that prevents relapse, basically. But what's it going to look like? It's going to relieve withdrawal for at least 24 hours, and it's going to limit cravings. Cravings, it's not possible to eliminate completely cravings with a medication because they're a more complex biopsychosocial phenomenon. So it's important to have that in the back of your mind when you're talking with somebody about cravings. Their medication is not expected to relieve that completely. As pregnancy progresses, some women will need to go up just because of the physiologic changes in pregnancy. Others will be able to function well by just dividing their dose of methadone and taking part in the morning and part in the afternoon or evening. Now, by contrast, methadone is what's called a partial agonist, which means there's a limit to the effect. There's a point at which when you take more, it's not going to do more. There's kind of a cap on it. It also is an antagonist like naltrexone. And it does that despite being an opiate because it binds all of your opiate receptors in your brain and binds them so very tightly that most other opioids cannot bind them to create an effect. So your brain's opioid receptors are saturated, but they're only getting a partial stimulation. People are less likely to develop tolerance because of that, but they are dependent on it just like they would be any other opioid. Buprenorphine is usually formulated with naloxone in combination. This is to deter abuse of the product, but in pregnancy, we recommend providing just the buprenorphine only product. So dose adjustment and effective dose for buprenorphine is about the same as for methadone. Either of these can be used in pregnancy. It used to be that methadone was preferred, and now the recommendations are that either one can be used based on what's most appropriate for the woman and what is also available for the woman. It's not advisable to switch a stable woman who becomes pregnant to methadone, for example, if she was stable on buprenorphine or vice versa. Sometimes you will see that happen because the provider that's caring for her is not comfortable managing her while she's pregnant, and so she'll get shifted over to methadone. But there's not a medical or physiologic reason for that, and it's a practice we are working to discourage. And then initiation of treatment, again, it needs to be individualized. What's going to work best for this person, and what do they have easiest access to? This is just kind of a little summary of dosing as it impacts pregnancy. So if basically you're preventing relapse, you want to relieve withdrawal and reduce cravings, but you also want to not cause euphoria or sedation. If you're seeing sedation in a patient who's on methadone or buprenorphine, it may be an indicator that their dose is too high or that they are using other substances in combination with their medication. Dose adjustments need to be made based solely on a medical assessment by a health professional. And again, I want to kind of reiterate what I said before. There's no amount of medication that can make you into a happy, healthy, functional person. That really requires behavioral interventions and individual therapy or group therapy that results in personal growth. The medication is not going to accomplish that. So treatment settings. Opiate treatment programs have traditionally been where methadone is provided. These programs can actually provide both methadone or buprenorphine and naltrexone, as well as other medications. They can do often psychiatric care, and they can do smoking cessation and so on. Opiate treatment programs are certified by SAMHSA, registered with DEA. Typically, they're certified and or licensed by the state, and they're accredited by an independent nonprofit that's approved by SAMHSA. They have a medical director and sometimes other physicians, nurses, counselors, and usually specialized services for pregnant women or women at least. One of the features of opiate treatment programs that is most associated with improved safety is the ability to do daily observed dosing. So we know that the medication gets to the patient and nowhere else, and that the patient is compliant. We know when a dose is missed. So it's an important advantage of the opiate treatment program setting. Now, the other treatment setting is with the so-called waivered provider. So this is a physician who has gotten special permission to treat addiction, opiate addiction, with buprenorphine. They have to take an 8-hour training and get a waiver from SAMHSA, and they're registered, they get a special registration with DEA. Recently, a new regulation was put in place creating an upper limit of 275 for specially qualified physicians or physicians who work in practice settings with specific, that meet specific criteria. There was also recently a law passed that allows advanced practice nurses and physician assistants to prescribe buprenorphine at the lower patient limits. This has not yet been implemented, and it'll be implemented sometime over the course of the next few months. So you may see new treatment providers engaging with this. Now, polysubstance use is a common problem in opiate use in any form of substance use disorder. The medication is only going to be treating the opiate use. The behavioral therapies are needed to address other behaviors, or an individual may need medication if they have an alcohol use disorder, and those can be offered concurrently for opiate use and alcohol. Longer duration of treatment is associated with a better overall outcome. We don't recommend that people receiving medication-assisted treatment for opioids be discharged if they relapse or if they use other substances. This is basically discontinuing their treatment because they're having symptoms of the disease that they're supposed to be being treated for. So it doesn't make very much sense. Sometimes a medication adjustment can help with the polysubstance use, but normally we recommend adjusting the dose of the counseling, if you will. Now, when ongoing illicit or polysubstance use is happening in the context of pregnancy, it does not completely eliminate the benefits of medication-assisted treatment for that fetus. It is usually a contraindication to breastfeeding, and the fetus may not get the benefit of achieving a typical birth weight. They may be low birth weight, but by and large, the fetus is safer with mom continuing on medication-assisted treatment, even if she continues to struggle with other substances. You heard a lot about alcohol and tobacco exposure. I can't, we focus very much on the opioid problem right now, but alcohol and tobacco are very common. They are known teratogens. They do impair growth and development. They do cause neonatal dependence and withdrawal. And they interfere with the metabolism of the opiate for the mother, so make it harder to stabilize on her dose. So these remain important issues, and it can be difficult to put all of that on the plate and have a management plan for all of that, especially with the amount of attention that the opioid problem is currently getting, which is understandable. So a couple words just about how other substance exposures might impact a pregnancy, with or without medication-assisted treatment. We know that cocaine is associated with a range of pregnancy complications, including placental abruption, which is detachment of the placenta from the uterine wall, and precipitous labor. So this is a labor that happens really fast. Oftentimes, mom delivers at home. Sedatives such as benzodiazepines are a much bigger problem than I think we're currently successfully messaging. They are associated with overdose, and typically, clinically, what I've observed is that they tend to cause some inattention to the development of problems in the pregnancy and often inattention to the onset of labor. So you'll have another woman who comes in and she may not deliver at home, but she'll deliver very soon after arriving at the hospital because she just didn't pay attention to the signs of early labor. And anything that jeopardizes mom's freedom, such as illicit substance use, jeopardizes her treatment and the safety of the infant. Moms often require other medications during pregnancy, serotonin reuptake inhibitors, Prozac, Zoloft, those types of things. Some moms require benzodiazepines. They may become diabetic or hypertensive during pregnancy and require medications. All of these are subsequently, the infant is exposed to them, and they may play a role in how the infant appears at birth and how they develop initially. Serotonin reuptake inhibitors, for example, have an associated withdrawal syndrome for the infant. And all of this will be going on together in a way that can be difficult to sort out. And our tendency clinically is to attribute it all to one thing, and we usually try to blame it all on the opiates. Now, there are lots of things that professionals who are interacting with a pregnant or parenting person can do to help them get the most out of medication-assisted treatment. And a lot of it has to do with encouraging preventive and prompt medical attention. Unfortunately, people with substance use disorder often have negative experiences with healthcare professionals, and they sometimes need some support and encouragement and even some coaching when they're going to go to even just a regular doctor's appointment for a concern or a complaint. Sometimes the experience is so negative that the benefit of preventive care is sort of outweighed by the negativeness of the experience. And so you need to kind of help them shift that balance. Promoting healthy diet and lifestyle, including smoking cessation, is really important. And the other thing is encouraging patients to allow communication among healthcare providers, but also people who are involved in managing the case, is very important. And a lot of times, people with substance use disorder have, like I said, had negative experiences with healthcare professionals, and so they're not very trusting or willing to share information. And I think this is my one exciting slide with the animation. Stopping smoking can be huge. It can be more important even than completely stopping, if illicit opiates. And I'm going to explain a little bit more when we talk about neonatal abstinence syndrome, why that is just so incredibly important. So let's talk about the fourth trimester, the postpartum period. This is when you might be in the home and you might still see this birth mother. How many of you are parents? Yeah, postpartum, not a good time to stop taking your medication-assisted treatment. It's a very stressful time, major life changes, even if you're not a first-time parent. There's a very high risk of relapse. One of the things that happens is with people with substance use disorder is when they have something to celebrate, they get high. And when they have something that they're sad or angry about, they cope with it by getting high. So whether they're stressed out about the baby or very happy about the baby, there's going to be a strong impulse to deal with that by using drugs. So whether it's just a one-time use or leads to a full-on persistent relapse, this period is incredibly challenging. And it's one where frank conversation about, well, how are you going to celebrate the birth of your baby? And how are you going to deal with the stress and the risk for relapse that this represents? You don't have to have the answers to those questions, but just asking those questions can be extremely helpful. As you well know, there's often a drop-off in services. There's certainly a loss of status. Pregnant women are often, showered with positive attention, but the tired woman with the screaming baby does not get showered with positive attention. And baby's no longer attached to mom's blood supply, but the baby is just as dependent and vulnerable as before. So I think the main take-home message is this risk for relapse due to stress and limited coping strategies, and the need to continue medication-assisted treatment. I'll just say this is not something I have evidence to support, but I know that there's a strong tendency to want to encourage mothers to get off of medication-assisted treatment. People understand that it helps assure a better pregnancy outcome, but we're kind of not mentally, cognitively there to say, yes, and you should continue this because parenting is hard. We're kind of in this place where, okay, now that the baby's out and okay, we're not that interested in how well you do, and so the medication-assisted treatment gets tapered off, and then we see these babies being taken out of homes in the first year of life. I don't know, is there a connection, but it certainly seems like an area that we could work on. There's some tricky stuff around medication management in the postpartum period. And I'm sharing this with you because you may be making a home visit and see a mom who looks not just like a tired mom who hasn't slept, but is having trouble staying awake. And that may be an indication that her methadone or buprenorphine dose that was increased during pregnancy because of the physiologic changes now needs to be brought back down. And we recommend treatment providers and obstetricians, pediatricians address this while the mother is in the hospital, but this doesn't always happen. So something you can do is ask, what time did you take your medication? Because peak somnolence will be 3 or 4 hours after dosing. Mom may need to come down a fair amount, 10% of her dose, if it's methadone. She may be afraid to do that because she may be afraid that's going to put her into withdrawal. So she may just need some encouragement to follow physician recommendations and work on bringing her dose down to where she can stay alert more of the time. And you may have to address this several times, especially during the 6 weeks postpartum. The other thing, of course, to be concerned about is if mom is having somnolence, has she relapsed? So if she's on MAT, I would approach it as a dosing issue and then subsequently as a possible relapse issue. So just some context for you to kind of have in your mind as you're looking at an in-home situation. Pain, unrelieved pain, even if it's not that intense, the idea that it's unrelieved and you don't know when it's going to go away can be enough of a trigger. You will see some women receive short-term opioid therapy, a few days of Percocet or something like that. And this should be supervised with her various treating health professionals. But you shouldn't be terribly alarmed if you see that, because women postpartum who have opiate dependence should basically receive the same treatment as another woman who gave birth with similar complications or not. Now, breastfeeding we actually recommend. The only time you don't want to breastfeed is if you're actively using other substances. What happens is a little tiny bit of the methadone or buprenorphine is in the breast milk, and this allows the baby to get a little bit of that medication. And then they wean themselves off because babies get hungry, and so they start eating solid foods and drink less breast milk. And so they self-taper off of breast milk, and they self-taper off of the mother's methadone or buprenorphine. Babies who breastfeed are less likely to need medication for neonatal abstinence syndrome and generally have milder neonatal abstinence syndrome. So this is a very important intervention for both mother and child because this baby will get all the benefits associated with breastfeeding, which are numerous, and a little management or mitigation of any neonatal abstinence syndrome they may be experiencing. Other things that have to be kind of factored in, some moms they have hepatitis C, they just are not comfortable breastfeeding, although it's not contraindicated. Other medications they may be on, and of course cigarette smoking needs to be stopped for the most part. And I sort of talked about the self-weaning. Now, an infant who was exposed to opioids in utero, about 60 to 80% of babies will have some degree of withdrawal. And keep in mind that withdrawal from nicotine and other substances looks a lot like opiate withdrawal, so these numbers are not necessarily very clean. We don't have a clinical tool that allows us to distinguish which of the various substances the infant was exposed to is causing the symptoms we're observing at birth. But most of those babies have very mild symptoms and don't require medication. Sometimes we fail to maximize the palliative interventions we can give a baby: swaddling, holding, dark, quiet room, skin-to-skin contact with mom. And we get a little alarmed and we kind of slap those kids in the NICU where it's light and noisy, and we may inadvertently be exacerbating the situation. Certainly knowing whether mom smoked during her pregnancy is going to help you know a little bit more about what's going on with this baby. And then again, withdrawal from psychiatric meds like antidepressants and benzodiazepines may be happening simultaneously. And those types of withdrawal will not be improved by the therapy that the baby gets for the opiate withdrawal. So you may get a picture in your mind of a baby who's like very sick and has opiate withdrawal that's not responding to therapy, when in fact the opiate withdrawal is responding fine to the therapy. It's the other withdrawals that are still manifest. So it's just important to have a little bit of a nuanced interpretation so that you don't get kind of sucked up in drama and panic. Now, this is a set of recommendations that we're beginning to put out and clinically translate for healthcare professionals who are taking care of infants with neonatal abstinence syndrome. I'm not going to break them down, but you will see that I highlighted the one, which is the non-pharmacologic methods need to be maximized. It can prevent the use of pharmacotherapy, which is essentially the ongoing exposure of this infant to opiates, and it can also minimize the need for pharmacotherapy. Now, I mentioned earlier, and Nancy mentioned, that alcohol exposure and tobacco exposure require specific developmental assessments and follow-up. Opioid exposure in utero is not associated with a specific developmental or growth abnormality. Infants exposed only to opiates, and particularly if it was medication-assisted treatment, can be expected to grow and develop normally. That said, concerns about their development should prompt an assessment. As we learned recently from literature published about 25 years after the sort of crack epidemic and all of the infants exposed to crack cocaine, the stability of the home environment and poverty are more likely to be associated with poor development or poor growth or poor outcomes later in life. So that really needs to be our collective society area of focus for these children. Now, what follows here is kind of a list of resources. The one slide that I presented that had the specific clinical recommendations for healthcare providers is part of a bigger document that you can access at this link. It is out for public comment until the weekend, but I imagine you're going to be busy at your meeting here. But it's still there at that site if you want to take a look at it later. These are a couple of resources on medication-assisted treatment, naltrexone, which may be of interest to you since some caregivers may be treated with that medication. This little one that's on the left for you has a nice little summary of all three medications. That's a very easy reference. And then this is kind of the big book, if you will, on treatment with methadone, and then the big one on buprenorphine, and a short update on the different types of buprenorphine. And this has a nice, the one on the right, has a nice little graph or table that will show you like the different brands and generics and what the doses are, just to give you some touch point as to what somebody should be getting. And then the SAMHSA's Overdose Prevention Toolkit. And if you don't have these links handy, all of these can be found at samhsa.gov/publications. And that concludes the comments that I had prepared, and hopefully I left us some time for questions. Okay. So we do have a few minutes for questions. Now, I can't see you all out there very well, but I do think there's a microphone in the middle here, if you would like to ask anything. Okay, we have somebody walking up for a question.
Thank you so much for the really interesting and educational presentation. My question is, I mean, I'm relatively new. I don't know much about this area, but I'm wondering, I hear about these infants going through opiate withdrawal, and I'm wondering, like, what are some of the signs or symptoms of that, and how is it diagnosed and distinguished from other potential problems, you know, in infancy? Thank you.
Okay, great question, thank you. The way that it's diagnosed is basically history of the mother and tox screening of the mother and the infant, but also with the application of usually a screening instrument. And it involves usually nursing staff assessing the infant on a schedule for certain parameters. And it may have to do with how hyperactive their nervous system is. Babies are kind of twitchy anyway, but these babies will be twitchier. Concerning symptoms would be not feeding well, not sleeping, maybe spitting up or having diarrhea to the point where they're not gaining. Even, you know, we look at weight in terms of grams in the neonatal or the newborn period. So the screening instrument that looks at and rates these symptoms over time is validated, and it should be used. It should be guiding the treatment decisions for the infant in terms of what interventions they need, whether they go to NICU, whether they get medications. However, it requires a lot of staff training and retraining to assure that there's inter-rater reliability, so that the next shift of nursing doesn't kind of score on the 1 to 5 differently than and then we think the baby's doing worse. So this is an area that really needs more research, so that we have ways to monitor that are not so dependent on subjective signs and subjective assessments by, you know, even well-trained health professionals. You're going to have some variation. So that's kind of it in a nutshell. Now, the problem is that nicotine withdrawal causes all the same symptoms. So that's where testing and the mom's history come in. And it's the provider's professional judgment that has to come in is like, how much of these symptoms do I want to medicate away with morphine for this baby versus, you know, potentially I'm treating nicotine withdrawal with morphine. And that can be a hard call, especially it's distressing to see an infant that isn't thriving. So you tend to want to medicate them and make them better, but then you over-sedate them. So that's where it's just not a nice, clean diagnostic and treatment process that really needs a good deal more research done on it. So I'm sorry, that was probably more than you needed. Is our questions, how do we know if there are questions from our remote participants? Okay, thank you.
Yes, I had a question, actually a comment and a question, and I'm wondering if you could give us any of your insight into that. When you were talking about chronic illness, that addiction is a chronic illness that's episodic, it reminded me of kind of episodic chronically mental illness. And I'm wondering if there's any overlap there, or thinking about systemic interventions that we need to use in child welfare for both of those things. And if there's any way to kind of coordinate the care or learn from one side or the other to inform either chronic mental illness or to inform substance addiction.
Why don't you talk about the chronic care model, and then we can think about the implications for child welfare.
Okay. Good question, thank you. The approach that we take at SAMHSA is a recovery-oriented model. So we're interested in not just attaining abstinence or engaging in a treatment episode, but how does that person engage in life long-term and have meaningful activity, employment, realize their potential as a human being. So that's a pretty much life-encompassing process, and that's the model that we're putting forward. Now, in the course of achieving recovery and maintaining recovery, it's not necessarily going to be a linear course. You may need medication at this time and not at this time, and then need medication again later. It's the same, so it requires continuity of assessments and ongoing engagement long-term. And by that I mean it needs to stay on your medical history, and you need to have access to trained providers who can check in with you on your recovery and challenges to your recovery, triggers, and so on. So the recovery model applies to all forms of mental illness, whether it's a substance use disorder or a mood disorder or thought disorder. So that's kind of the approach that we would like to see health professionals and treatment providers be taking as a whole. So I don't know if that
And I
gives
think the implications for child welfare is, how do we know that that's what's going on in the treatment setting? What's that communication path? What are the indicators that child welfare needs to know to say, this is a parent that's on this road to recovery, particularly during those first 6 months or perhaps the year that a child might be staying in out-of-home care, or hopefully less than that as reunification happens. But that's the real work of the collaborative between child welfare practice and substance abuse treatment practice, to understand what is it that child welfare really needs to know about what's going on. And communities that have gone through that effort to say, this is what we need to know at these points in the case. We're coming up for a 6-month court review. This is what I need to know before that. You probably want to know each month what's happening. And the most sophisticated collaborative practice sets up those communication pathways. We have some tools to help you do that, so that we're not waiting until there is a return to substance use before child welfare is aware of what's going on, given appropriate communication, appropriate releases of information, and really using that as a motivation for the family, particularly in a case in which the child's been removed, to use that partnership as a way to say, this is your opportunity as a family to inform child welfare and inform the court about how you're doing and are you on the path to recovery. So it's a real way to ground that collaborative practice in this communication.
One thing that I haven't heard mentioned is contraception, and I think that's an important part of recovery, so that women don't have unintended pregnancies during the recovery period. We have a program where we actually go out, we've partnered with the treatment facilities, and we go out and do education with the women on long-acting reversible contraception. Mm-hmm. And then the treatment facilities will provide transportation to the health department for us to place long-acting reversible contraception for free, or we provide transportation for those women.
You're absolutely right. Excellent point. Thank you for bringing it up.
Yes, thanks.
Elaine, did anything come in from I see little index cards flying around, so.
We have 2 questions from online, so I'm just going to choose one because of the time. Given that substance use disorders are often intergenerational, do you have recommendations on what child welfare agencies can do to prevent substance use disorders for older youth?
For
Older
youth. I think, one of the phrases that we use frequently is the best prevention for children is treatment for their parent. And we certainly saw that play out in the Children Affected by Methamphetamine demonstration grants. Frankly, I didn't expect to see long-term changes in reunification rates and repeat maltreatment rates from the kinds of interventions that were envisioned, which were often strengthening families, celebrating families, taking care of that parent-child relationship. And in fact, by those 2-generation programs, it drove better outcomes in those programs than any of the others that we've seen. So I think that's a critically important point, is understanding using good assessment tools of which of these children and parents need repair of that relationship. And what we see in the data is about half are very well attached. And have very good relationships. So knowing how to differentiate which family needs more intensive services like PCIT or parent-child psychotherapy, more intensive kinds of services versus the kinds of parenting programs which are 2-generation, which gives that child the opportunity to share with other kids, with peers, particularly in the junior high and high school age groups, about being able to share with each other about their life experience as a child of a person with a substance use disorder. It's incredibly powerful to see kids being able to have that experience of peer support and exchanging with others.
I think you have another question, so you've said everything that needed to be said on that point, I think.
Sure, okay, so we do have one more question. What if an infant is born with opioids in their system, but the mother refuses a tox screen? Do you have any advice, and what is the best practice for placement of an infant in this case?
Okay. If I heard you correctly, it's like if the infant tests positive but the mother refuses a tox screen, what do you recommend? Physical exam and history for mom are also very important and can sometimes tell you as much as you would find out from a tox screen. Tox screen usually has a very narrow window. It's only going to pick up use in the last couple of days. But, mom's engagement in treatment and medical history and how she looks physically can tell you just as much. So it's not usually worth getting into kind of a battle with mom about, because it's her right to not give you consent to test her for drugs of abuse, and focus instead on the other resources for information, treating providers, the medical record, the medical history, what she reports her history to be, and her physical exam while she's in the hospital.
The other thing I would just add to that is that we have to make sure that we're framing that in terms of it's not the use in and of itself, it's about the risk and the safety factors for that infant and for that family. So if we move from this idea of detection to engagement, engagement in services, engagement in making sure that there's a plan of safe care for the family, it changes the importance of the actual test to, is that a way in which we're engaging parents in this change process of treatment and recovery? I think that means that we have exhausted our time. Thank you so much for all of you who are in the room and joined us virtually.